now. And I would turn the floor over to Dr. Quintero.
All right, thank you, Patrick, and welcome everyone to our global health seminar series. Today, I am just thrilled to have Dr. Mark Nichter here to present some of his recent work. Dr. Mark Nichter is a Regents Professor Emeritus and former coordinator of the Graduate Medical Anthropology Training Program at the University of Arizona. He has a doctorate degree in anthropology from the University of Edinburgh, as well as an MPH from Johns Hopkins University, and has conducted postgraduate training in clinical psychiatry and clinical anthropology as well. He holds joint appointments in the departments of family and community medicine and the Mel and Enid Zuckerman College of Public Health at the University of Arizona. And his publications span a very broad array of public health problems. And he is a recipient of many prestigious awards, particularly within medical anthropology, and has served as an advisor to several international health and development organizations. And he is currently engaged in global health and health disparity research, and is a member of 3 COVID-19 related task forces, and is the co-founder of hcw-hosted.org, and that's a 501c3 that is dedicated to supporting healthcare workers and their families during the COVID pandemic. And Mark today is going to be talking about one of his current projects, developing a Braille Ulcer community of practice in Bankim, Cameroon. And just a heads up, folks, a content warning. If any of you are eating lunch, you know, we're going to be seeing some slides of this affliction that are going to be well, perhaps a bit graphic and you not very appetizing. I'll just put it that way. Okay, so that's your heads up, folks. So all right, welcome, Mark. Thank you for being here.
Thanks, Gilbert. Can you hear me?
Yes.
Okay, one second. How's that? Is that better?
Yes.
Okay. So what I want to do today is really not just talk about a disease. I'm going to talk about a disease, of course, which is probably a disease that none of you have heard of before. It's a flesh-eating disease that is rampant in West Africa. But the point of the presentation really is to talk about creating communities of practice and illustrating in public health terms why they're effective and how we might want to think about using them for a whole variety of health problems. So I'm just using this disease as a way of highlighting communities of practice. So let me talk about the disease itself. I don't imagine many of you have heard of Braille ulcer. It's a neglected tropical skin disease. It is caused by a toxin-producing microbacteria. It's the 3rd most common microbacteria disease in the world, aside from tuberculosis and leprosy. And the large majority of cases are found in Africa, although you do find some in Japan and Australia. What's really interesting about this as a detective story is that even today, after 30 years of very intense research, we really don't know the mode of transmission. We know it's not contagious among humans. We don't know what the incubation period is. And the early symptoms mimic many other kinds of unpainful health problems, skin problems. We also know that in West Africa, a large majority of the cases are initially taken to traditional healers. In the early stage of the disease, one gets like a nodule as kind of a symptom. It looks like it could be an insect bite or a small wound. It doesn't hurt. It may itch just a little bit. And if you don't take care of it, you don't start treating it, and I'll get into the treatment in a minute, it develops a small ulcer, usually 1 or 2 centimeters in diameter, and starts manifesting as a nodule. If you don't treat it by this stage, it starts becoming worse. It can become quite severe. And if it becomes very severe, the only way of treating it is really by both giving antibiotics and surgery, often plastic surgery requiring a skin graft. 50% of people get this disease are children between the ages of 4 and 15. But even some very young babies can get this disease, and it affects all age groups. Where does the disease manifest? Most of it manifests, it can manifest on any part of the body, but 90% of them, the manifestations are on the limbs, and about 60% of all manifestations are on the lower limbs. So this is what the kinds of cases look like that you see coming into the hospital, because you don't see the early cases coming in. If this is not treated effectively, it can lead to osteomyelitis, and then you have all kinds of incredible problems in terms of having to adapt to disability associated with that. And it's for this reason, and here's the main point that I'm trying to make here, is that it's for this reason that you got to catch this disease early. If you can catch it early, there is treatment for it. The treatment takes a bit of time, but it is very effective treatment. And you also have to get people to realize that you're not just dealing with this initial ulcer, but this thing can spread around the body. How about diagnosis? Well, a lot of the diagnosis is presumptive. The problem is in the early stages, this problem doesn't really hurt. There is a certain feel to the nodule. And if you become trained, you can, in some cases, not all, but in some cases, actually be able to actually sensorially feel the difference between this and other kinds of other types of ulcer by feel and also by touch. The physical diagnosis is not accurate enough. There's lots of false positives. It really needs lab confirmation, and that really requires a PCR exam, which are hard to come by in many parts of Africa. They're expensive, there are very few reference labs, and very often people don't get results back for quite some time. Well, there is still, as of yet, not a simple and rapid diagnostic field test for Braille Ulcer, although there are several funding agencies working on this. Is it treatable? Absolutely. It's treatable with about 58 days of injections and pills. The treatment is highly effective if you catch a case early. We have actually a new treatment that's being tested right now, which is cutting down the number of days to 30 or 40 days, but that still has not been released. So if you catch this disease early, and if you can get people to take medication for the number of days that they need it, then you can avoid getting these very serious lesions that require skin grafts. And when you have someone who gets a skin graft, they could be in a hospital for anywhere between 6 or 7 months to 2 years. So what's the point? The point is you got to catch this thing early, and you've got to raise community consciousness about bringing in these cases so that they can be identified. So what's the cultural context behind all this? Well, you saw what this disease looks like, and the symptoms, once they become severe, look extraordinary. They're very long-lasting and painful. And the thing about this disease is very often one household or someone in one household in a village will get it, but their neighbors won't. And their neighbors are pretty much doing the same things that they are in terms of work, living conditions, getting water. So it sets up a situation where people think it could be witchcraft or sorcery or some sort of malevolence by supernatural forces. And the question always is, why did this particular household or this particular person get this disease? when the other 30 or 40 households around them did not. So for this reason, cases of this disease are often taken to exorcists as well as herbalists. These are what some of the folks look like who are treating these particular kind of illnesses. And they often keep their patients for quite some time. Herbalists as well as exorcists are very often gone to for treating this disease. And one of the big problems about early ulcer, and I would say one of the big problems about almost all tropical skin diseases, is that people, and I would say this is also true of Montana and Arizona, is that people have this, this wrong notion that drying out a wound is healing it, right? You put something on it to dry it out. And the problem is that drying out a wound actually is very bad for wound healing. We can get into that in the discussion period if you want to, with a new intervention we have on that. But also, even if it did, you're not curing the disease because it's highly systemic. So even if you close the wound at one particular point, the microbacteria just travels to someplace else and have another manifestation. What are people using? They're using all kinds of caustic materials as well as herbal materials, battery acid, kerosene, tetracycline tablets that are opened up and rubbed in a wound, all kinds of things that certainly exacerbate the problem and do not help it. So what I will do now, that's your background. What I want to now is give you the findings of a 5-year community-based health service research project that we mounted. It is still going on, although as some of you may know, Cameroon is undergoing what is close to a civil war right now, so it's kind of hard to get data between that civil disturbances and COVID. But I'm just going to give you data for 4 years because it's enough to make my point. So where is this area? It's incredibly remote, part of Cameroon. Up until recently, there wasn't really a road there. It took many, many hours off track to get to this area. Multiple ethnic groups with multiple languages live in this area. The local chiefs and traditional healers are greatly respected and very important and have a lot of big role in the leadership and in the communities there. What was the goal of the intervention? It was to establish a community of practice. I'm going to tell you what that is in a second. Composed of local stakeholders who work together to do 3 things. To detect Braille ulcer, especially in its early stages, because that's what we're trying to do. To reduce treatment delays so that after people realize they might have this illness, they actually take the treatment. And then to increase treatment adherence and reduce dropout. Those are the 3 big ones. The 4th one, though, is to also illustrate that health system strengthening can be greatly affected by community collaboration. So to achieve this goal, there are 3 main objectives: to create an interactive Braille ulcer outreach program that's culturally sensitive. And in order to do that, you really have to foster collaboration between health staff and community stakeholders. How do you go about doing that? So it's not just a question of giving information. It's a question of giving information that starts a dialogue between both what biomedicine thinks is going on and what the community thinks is going on. To test whether it's possible to involve traditional healers in this Braille ulcer community of practice. There was a lot of resistance by the WHO, who we were working with during this project. In the beginning, they were basically saying traditional healers are the problem, not part of the solution. They're keeping patients, they're delaying treatment. We're not sure we should be involved with them. And it took some doing to be able to actually bring this on as one of our objectives and to study it scientifically. And then the 3rd one is to provide support to patients who have this illness and who have to be treated for a couple of months at least. And how can you provide them the resources so that they can adhere, not just because they think the treatment's effective, but they can pragmatically get food, have transportation, so forth and so on. So what's a community of practice? A community of practice is not a network. communities of practice mobilize around issues of importance to different kinds of people who would not normally interact with each other. And it's really trying to get them to problem solve together where each recognizes that the other has something to contribute. So the reason I say it's not a network is because it's really based on informal relationships to address this issue. And in our case, in this case, it's recognition of this particular disease. So we're really looking on how to leverage weak ties between community health workers, healers, hospital staff, and researchers. So who are the stakeholders? Just the people I just mentioned, including also chiefs, religious group leaders, teachers, so forth. So the cornerstone to developing a community of practice is getting everyone on the same page. So how do you go about doing that? Where do you start? So one of the places we decided to start was by having an education program developed that was innovative and interactive, and really started off by using formative research to take a bottom-up approach. In other words, let's find out what people think is going on. Let's see what their questions are. Let's try to engage them and a question answer based on what they want to know, as well as telling them what we think we would like them to know. It's based on formative research. We were really trying to find out what people wanted to know, addressing doubts and misconceptions about treatment offered by government health facilities, a lot of translational research. How do you communicate to people? What kind of messages do you give them? And how to make the program interactive as opposed to top-down and just a presentation. So I'm going to tell you just a few things that we used. In West Africa, as in many parts of the world, a lot of people engage in analogical thinking. I'm just giving you an example of one of the analogies that we found worked very well to start a dialogue between local ideas about health and biomedical ones. And that was really the idea of roots in the tree, that if you have, if an illness has very deep roots within the body, you can't just chop off the top of the tree or chop off the top of a weed and think that you're getting rid of it, because what happens? It just grows back or it travels someplace else. So the idea here was, people would say, if our wound dries out with traditional medicine, why do we need to take this medication? And the idea was to get at the roots, because otherwise the roots are just going to pop up someplace else in the body. And this is the sort of thing that got people to have a dialogue. They talked about it. They talked about their experiences. We had before and after cases, pictures of before and after, so that people could actually see how this transpired over time. Our approach to outreach education was delivered via PowerPoint in an area that doesn't have electricity. So we're using a lot of car and motorcycle batteries. Thank goodness that, these days you can still have a small projector and a laptop that you can strap to the back of a motorcycle and get it out to some of these more remote areas. It was iterative. The reason why we use PowerPoint is because every time someone asks us a new question or raised an issue, we could change the presentation on the spot. All right, so it was an iterative process. And we empowered staff to be able to change things and to be able to experiment. We had a lot of visuals that were evocative. People that we were dealing with in the community were far more receptive to visuals than just words. We had to do translation into multiple languages because, and simultaneously, because people would show up at some of these events for different language groups. And most important, we invited people to ask questions, and we tried to engage in answering those questions in real time while the presentation was going on. We also had a lot of testimonials where people who had actually been treated effectively got to tell their story in front of the entire community, which was really taken right out of some of the more Pentecostal church services that go on in that area, and people were familiar with this testimonial business. So I'm not going to go through all this, but the 9 sections of the education package that we had Really, what are the signs of a possible Braille ulcer? What are environments where a lot more of this occurs? I could get into that later if you're interested in it. What does clinical staff do to determine whether you have the disease? Why are they taking blood from your body? What are they doing with that? Ineffective and effective treatments. Traditional healers were congratulated for referring patients and taking care of the supernatural, while they let healthcare providers take care of the disease and the disease roots. And we had a lot of before and after pictures of people who had been treated successfully along with these testimonials. So that combination seemed to work quite well in terms of how to do the outreach program. These outreach programs were huge, huge. People really showed up for them. I'm just talking about 44 of them that happened in Cameroon. We did this in 2 other countries as well. We had over 12,000 villagers attending these. And you can see they're quite engaged. That picture on the screen there is an anthill, and we're actually talking about anthills and the skin and how things get inside of your body and how you have to protect wounds. And these were the kind of things that everyone would engage in a conversation about. They were attended by children as well as adults. A lot of the kids asked some of the best questions. We had a lot of facilitation of health staff who acted as spokespeople. The person on the left there is a male nurse. The person on the right is a community health worker. Very often these guys would work together simultaneously, speaking 2 different languages around the same point, or more than 2 languages in some cases. This translation happened. We found out that some of the very best communicators were actually community health workers. This is a community health worker speaking Pidgin to a large group here. And what's incredible about him is that he's a Fulani, which is a group that really uses the health services in Cameroon less than any other possible group. He was a very effective communicator. Open discussion was invited. There were a lot of people who wanted to ask questions. Now, I have to tell you, the funny part about all this is these people had never heard their own voice on a microphone before, and they loved the mic. Our biggest problem was everyone wanted to say something just so they could hear themselves. It was a big thing. We had an amplifier there where their voice was loud, and finally, we had to tell people, look, let's just keep it for question and answers. And then after the meeting's over, we can do karaoke or singing or anything else you want to do. But let's keep the mic for the questions at this point. We had lots of people asking a lot of questions. A lot of questions were asked, for example, about the use of antibiotic capsules, rubbing them into wounds, and why this wasn't a great idea. Former patients shared their experiences. This is one of my favorite former patients. I just have to tell you a story for a second here. This was a woman that was supposed to be married. She was being suited by a man, and she got really ulcer on her leg, and the ulcer started to stink, and she locked herself in her house for about a year, and thought she was just never going to get married, and why would anyone want her? This disease was spreading. It was terrible. She got treated. Her wound, even the scar, is relatively small. And she's a beautiful woman. And after her treatment, she had 3 guys chasing her, wanting to marry her. And she just was, when she gave her story about this, people sat there and clapped. They loved it. And it was like, okay, we see with an actual person here this huge difference that it made. We had pictures of her before and after. The other objective we had was to test whether traditional healers would participate in a community of practice. We had meetings with groups of traditional practitioners. They had their own local society. We got them to come on board basically by saying, look, you guys are in charge of the cosmos, the supernatural in this place. That's not what we do. We do not know what causes this disease, but we know how to treat it properly. Why can't we work together? So you take care of the supernatural, we'll take care of actually treating the wound. And the members of this group, there's a funny story behind this. They saw us taking notes every time we had a meeting, right? I'd be sitting there taking notes. My research assistant would be taking notes. And they decided that note taking was empowerment. So one of the traditional healers that knew how to write would write everything down that we would say. It was like, if you're going to empower yourselves by our voice, we're going to take your voice and put it down on paper. And this group of healers on their own, this was not our idea, decided they would only work with us if they had a contract. And they wanted to put the terms down for the contract. So we negotiated a contract that had 7 provisions. I'm not going to go through all of it right now, but after receiving education about Braille ulcers, they agreed to refer patients with Braille-like symptoms within 10 days. They would treat them supernaturally, the supernatural causes, but then they would refer within 10 days. They would not treat the skin of the patient. And again, I want to show you what their treatment was: scarification, battery acid, kerosene, herbs. They agreed to abandon those practices. They would agree to have a referral relationship with hospital staff, which meant that they could go to the clinic and be part of the treatment team. It was not that they were going to just hand their patients over to the hospital. No, they had to be part of everything, and that they would receive a small honorarium for referring patients. When I say a small honorarium, this is really important. This was not the idea that they were collecting patients to bring in to make money, because if that was the case, they would be accused of witchcraft, because the idea was that anyone who can heal can also create the thing that the disease that you're trying to heal. And then that would make them suspect of being witches that were creating the disease to make money. So they were very adamant about the fact that they did not want to be seen in that light. However, they wanted transportation and money for food so that they could go and visit a patient, have some food with them and talk to them, which seemed reasonable. So they had full access to patients at hospitals. They received feedback on all patients that were being treated at the hospital. And the other thing is they could participate in the education outreach program. So here are examples of the 65 healers that joined the group after a screening process. And I'm going to tell you what happened shortly about this group. The third objective was providing support. Initially, we had small money to do this, but we started creating halfway houses in this remote area. People couldn't get to a hospital for treatment. We developed these houses that were halfway between their villages and treatment center, and they could stay there. We gave them food while they were being treated. So that was the 3 things we tried to do. Now let me give you the results really quickly in public health terms. You can see a pre-post type of evaluation of what we were able to accomplish. So at baseline, community stakeholders did not refer any cases of suspected Braille ulcer to health stations. When I say community stakeholders, I mean teachers, family members, former patients, traditional healers, chiefs. There was just no referral. And the adherence to a treatment by patients at health clinics was poor. We introduced this intervention with the 3 parts that I just mentioned, right? The outreach program, the getting traditional healers on board, and having these halfway houses established. And this is what happened in those 4 years. Now, I want you to remember, and I'm going to go through this in a little bit of detail. You don't have to look at all the numbers, but just look at the bottom highlighted. During those 4 years, only 7 to 10% of all cases that were treated at the hospital were identified by hospital staff. Every other case was generated by the community, either by community health workers, traditional healers, or families of family members who had attended these outreach programs. I am most proud of the latter. So, what were the high points? As a result of the project, 93% of all suspected cases of BU by the community, 90% of all confirmed cases by PCR were confirmed by the community. So the community had gone from having no impact at all to having more than 90% of impact on the community. Rates of suspected cases were confirmed by BU were very impressive. They were incredibly impressive for community health workers and former patients and family members. And of course, clinical staff, you would imagine that's the case, but the difference between clinical staff and family members and former patients was not that great. Why was it so for traditional healers? It's because we tested far more cases than referred. In the case of people referred not by healers, we only tested them if the health staff thought it was necessary. That could have been one of the confounding factors here. Category 1 cases, which is most important. In 2009, before this project was undertaken, only 8% of all Braille cases were category 1. In other words, the only people showing up at the hospital were very severely ill. During the project, that completely changed. We had 522 suspected cases that were referred by the community. Half of them ended up being confirmed as BU. But the most important thing here is that 21% of these 266 cases they referred were category 1 confirmed cases. So this is incredible success in terms of getting these early cases, which can be treated fairly cheaply and without that much difficulty, as opposed to skin grafts and being in a hospital for 6 months to 2 years. Self-referral was incredibly important here. The education program seemed to really work. 40%, 46% of all referrals during the pilot stage were from household members themselves. But what's important is that once someone identified a possible BU case, they often then went to see a community health worker or a traditional healer and asked them, we think this might be it. Do you think we're right? And what they often wanted one of these people to do was to accompany them to the clinic, because that's not something they routinely did. So even though they were the ones identifying the cases, very often they asked others to come with them to the clinic. Referral by traditional healers. 5 years prior to our intervention, not one case had ever been referred to the health system. During the project, 19% of all suspected cases were referred by healers, 15% of all confirmed cases, and almost 20% of category 1 cases. So these healers really did have a big impact. Adherence to treatment. Prior project treatment abandonment was high, over 50%. During the project, treatment adherence rose to over 90%. How come? What happened? And I think it was both the provision of the resources in terms of helping them with transportation and food, but it was also the psychosocial support of traditional healers and community health workers. So how about these community health workers? The big fear was that after they were involved in the program, that they would just get more patients, become more famous, keep the patients, make money, and not refer them to the hospital. That was WH's big fear. If we involve these guys, they're just going to put a shingle out in front of their hut saying, Braille ulcer specialist, or the local term for it, and that they would actually end up sabotaging the program. That didn't happen at all. Of the 65 healers that agreed to participate in the beginning, 85% of them remained in the project for the entire 3-4 years. And out of these, almost 70% of them were proactive, meaning either that they actually referred cases, or they participated in outreach programs, or that they supplied psychosocial support at hospitals for these patients. So the vast majority of these healers actually became very effective team members. You can ask me in question and answer, what about the other 15%? I'll tell you about that. That's another story. There's always somebody, right? The contribution of healers, the important point I want to make was not just referring their cases, it was really checking up on them, making sure they didn't drop out, encouraging them, and giving legitimacy and respectability from a cultural perspective to the entire program. So that when someone was actually healed, the healers took as much credit for it as the doctors or the nurses did, that they worked together. And the healers were greatly welcomed in roles by the clinic staff. Why? Because they're overworked, and any that occurred, if they could just, reassure people and provide them some counseling and help them, anything that would keep them in treatment was considered a win. And here's just an example of what three of these healers look like. This is two of them on one side doing their round hospital, checking in on all the patients. Did it once a week. They were very effective. Here is another case where this one woman is complaining of pain, and she was thinking of abandoning her treatment. And they came in and said, no, you can't do that. What about the pain? And maybe your bandage is too tight, and your family's concerned about you, and we're going to do some ritual that's going to make sure that you're protected, so forth and so on. The one at the bottom is one of my favorite ones, which was a woman who was a healer who developed a very good working relationship with the local doctor. They used to go and see patients together. The government was very wary of legitimizing these healers as part of the healthcare team. All I can say is it took us almost 2 years, and this data that you're seeing right now for the government to say, no, we got it. They're doing a good job. Doctors and nurses seem to like working with them. We agree. They can be part of the team, and in order to legitimize it, they were actually given badges, which they were very, very proud of and used to wear while in the village. Very interesting. The halfway houses, we got money. They were also successful, so we were able to hustle up money to actually create ones that were not just some old shack that was. We were able to kind of actually create halfway houses that had proper well and basic amenities to them. We were worried that different ethnic groups who had never lived together, who were sick, would they be able to stay in the same halfway house? That was a big question we had, because some of these ethnic groups are not in the friendliest terms with each other. And we found out that the biosocial is the idea of community, of people sharing a common illness or a common illness experience, was actually very high. They supported each other. We had no problems with that aspect of the project. I'm just going to try to wrap up here pretty quickly. We did a process evaluation. We found out that everyone thought that this had worked out quite well. Communication between community health workers, healers in the clinic improved. And it was really a question of task sharing and task negotiation. Community health workers and healers now attend meetings at Kim Hospital and voice their opinion about cases, or asked about a particular type of case and why someone might stay or try to leave treatment. And these new relationships are really weathering the test of time. And now that mobile phones are being introduced, it's really interesting to see that a healer has the local nurse or doctor on speed dial, and vice versa. So if someone leaves the hospital and abandons treatment, a nurse will call up the healer and say, look, they're from your area, your village. Could you go have a talk with them about that? Impact evaluation, community health workers' status increased. Why? Because these community health workers were able to bring a whole outreach education program to the village, and the doctor or the nurse would show up, and a bunch of people would show up, maybe even a farter, and it was a microphone. This is all amazing. This community health worker status went sky high. Clinic staff felt more positive about being part of this because they said they had a much closer working relationship with the community. The hospital has increased in terms of people's trust and confidence for treatment of other kinds of things. That has actually caused a big problem now, because we have people coming from other regions who want to go to this hospital, and they're not really from that region. It's hard to turn them away, and that's become a resource scarcity issue, right? Where sometimes success is failure when something like that happens. The healers have continued to participate in these groups, even though funding of this project ended 3 years ago. It's still continuing on. And I think what was very important to emphasize here is that the social capital and status the healers gained from referring cases and participating was far more valuable to them than the chickens and the goats that they would have been paid for actually treating the patient. So, even though they didn't receive a lot of financial profit from this, they received a lot of cultural and social capital for being part of the team, and they looked at that as, for them, as more valuable. As one of the more successful healers said to me, he said, "Yeah, I probably lost a few goats in the trade." He said, "But I now have access to the hospital, the nurse, and when my son was sick, I got on my phone and I called up the nurse and I said, I'm sending my son to the hospital. He was given good treatment." So, I mean, this is the human social relational side to all this. Patients had far more trust also in the Braille ulcer treatment. I'm almost done here. The other thing that was rather amazing is I mentioned to you the Fulani, this group of pastoralists. They're nomads that drive their cattle across borders. They could care less people's idea of what borders are. They just go where they want, as they have done for centuries, probably. Some of them are armed right now with MK16, so you don't want to mess with them. And they really have no use for the healthcare system at all. And they had never sent any of their people to be treated for Braille. This was a young Fulani boy. This was how bad he looked. He couldn't walk behind the cattle anymore. His father had to push him on a bicycle. And his mother decided to come for treatment. He stayed at the hospital for 18 months. He ended up being able to walk again and deciding that he wanted to become a nurse, wanted to go to school, and had studied actually at the hospital itself. And her right now is one of our biggest advocates for this entire group that up until now really had not much use for the health system. Here's my update. I can only give you an update as of the end of 2018 because of what's happened in the country. Outreach is continuing to go on. Traditional healers are still active. Referral cards are now being used. That was not our idea. Now there's actually a card that a community health worker or a traditional healer can write on and give some information. And when they give that card to the clinic then gives feedback to the traditional healer or the community health worker to say how that patient is doing. The family have, in 2018, which was a very tumultuous year, 65 cases were treated that were referred, and healers had referred 12 of these cases. Most of them were from the community. Again, one of our problems was this project became so famous that we even had people coming from Nigeria wanting to be treated. And, what do you do with that? Do you turn people away? Do you take them? It's a whole other group of issues. My last slide here is that why is this important? Aside from Braille ulcer, which is interesting, what I'm trying to demonstrate through this case is that community collaboration in the form of communities of practice are possible. They are a form of health service strengthening. They strengthen the health system, and that the relationships of trust that you can forge around treating any particular disease creates relationships that can be used as a platform and a communication channel for dealing with other kinds of diseases that show up. And this, while this was going on, we had the Ebola outbreak happening across the board. And we were primed to work on Ebola with healers, community health workers, chiefs, and the health staff being able to work together on day one because they already had established relationships. So any effort to create a community of practice around any disease at all sets up the conditions and social relations to be able to launch a response to a new types of health threats in the future. And that's it. I said 40 minutes, and I think I hit it.
All right. Yeah, Mark, that was great. So thank you so much, Mark. Very interesting. We do have a few minutes, so I would like to open it up for questions from the audience. Anybody out there, if you just want to unmute your microphone and ask a question, or if you want to use the chat function in Zoom, you can type in a question there.
I have a question, Gil and Mark.
Sure.
Mark, thanks for that presentation. And I couldn't agree more about the communities of practice building work that you did, and absolutely see that as a component of health system strengthening. I was wondering if you could talk a little bit more about how you chose this particular disease process to focus on in the pantheon of diseases or health problems troubling this group of people. And also related to that, how did the local people themselves see that choice, like in comparison with other afflictions that they're dealing with?
That's a really good question. Okay, so the real story. I had no desire to work in West Africa on a flesh-eating disease. I'm mostly a South and Southeast Asianist. I was suckered into seeing this disease by a microbiologist friend that I worked with in India many years ago. And they have become one of the microbiologists working on this particular disease. And after 5 years of funding by microbiologists, epidemiologists, entomologists, geneticists, trying to track down routes of transmission, as well as trying to get people into treatment, they basically had not been successful. So people said, you know, we should get an anthropologist out here, some medical anthropologist. And somehow my name came up. The woman said, oh, I know this guy, I worked with him years ago. Let's just get him out here for 8 or 7 days and let him see the disease. And they brought me to a children's hospital with a bunch of kids having the disease. And as I said to Gilbert earlier, 8 years later, here I am. It's a hard thing to walk away from. So I would say it was chosen for me. I did not choose it, to be honest with you. But the important part of the story is not that. It's the second part of your question. What do people think of a research team going out and selecting one particular disease to work on when there's typhoid, malaria, all kinds of other problems that are in the community? And especially working on a disease that had supernatural associations with it. So we couldn't do anything before working with the chief. And the chief in that area, it's an area that the slave trade was involved in, was very suspicious of anyone who was white. And it took quite a bit of time to win over his trust. He thought that there was no reason that a team was out here trying to do something about a disease for his community unless there was profit in it for them. And he wanted to know what the profit was. I'm just being very honest. That was the first area, first thing. And that took some time for him to become involved and to be won over. The second thing, though, you're asking a really vital question, which is, how do people feel about a linear program? It could have been tuberculosis, HIV, whatever, any kind of linear program in public health. When we choose one thing and throw resources at it, people then wonder, why didn't you put resources into diabetes, HIV, malaria or something else? Why this one, right? And that is a big, big problem. And the other problem about this is that there are lots of other tropical ulcers out there. There are yaws. There is, there are all kinds of, there is forms of anemia. There are all kinds of things that can create skin problems. And we were offering free treatment for Braille ulcer. And people were saying, wait a minute, I've got an ulcer. How come you're not giving me free treatment? It's like, well, the medication's different. It requires a different medication. Well, why are you privileging that? And that became a huge issue and topic, so much so, and I was hoping someone would ask this question, so much so that we had to mount another intervention, which we're doing now, which is on all types of skin and wounds, including accidents. And we just decided that you cannot, if you want to win the community over and really get people to be dealing with neglected tropical illnesses, you have to take care of things that symptomatically look very similar. So our project that we've just finished a few months ago in 2 other countries has really taken up this idea that we really need to focus on what people are seeing as the issue. So we now have wound clinics for all types of tropical wounds, just like we might have a fever clinic for all different types of fevers, because people really are concerned about the symptoms. We happen to see these symptoms as signs of a disease. They look at it as symptoms that need to be treated. So that project that we're doing now has been very welcomed by the community, where they see this as people not being turned away just because they don't have the flavor of the day disease that people are offering free treatment for. I don't know if that answers your question.
It definitely does, and thank you. I appreciate your reply, and it also brings up all kinds of related issues with randomized controlled trials that are disease specific in communities like the ones you're describing here. And that's a topic for another time, but thank you. I'll stop there and let others ask questions.
All right, maybe we can get one more question in. Anybody? If not, I'll go.
Don't be shy, Montana.
All right, I'll go. So, Mark, this is kind of off topic, but before we came on for this today, we were chatting a little bit as we prepared for the seminar. And we talked a little bit about COVID-19 and kind of touched upon the broad topic of maybe how public health might have to change as a result of COVID-19. And I was wondering if you might share maybe 1 or 2 ideas you have about, about that issue.
Sure. Let me share one idea. Let me share the big idea that has ended up causing me great amount of moral distress, because it's a drum I've been beating since March of 2020. And that is a unit of analysis issue. One of the things that it doesn't matter whether I'm talking about COVID-19 or tobacco or other things I've done in my life, the unit of analysis is never the individual. It's the household. The question is, how does a particular illness affect everyone in the household, not just the person who happens to get sick? And until we learn that message, until our interventions are take stock of what the social formations are that we should be addressing, we're not going to be effective. So in the case of COVID-19, it was obvious at the beginning that 1/3 of the population of the United States, up until 1/3 of the population, they don't have a place to isolate. Especially if you're in a minority group, you might be living in a house with 6 other people in 2 rooms. Right? So if that's the case, telling people it's like, test, trace, and treat, that sounds great. If you test someone, what the fuck are they supposed to do? I'm sorry, my language. What are they supposed to do if they can't isolate? In Arizona, we had people living in their garages and 115 degrees temperature outside. People living in cars, trying to isolate. What are they supposed to be doing? There were no resources given by the government for this form of isolation, except a few cities that did something for the homeless. If you look at successful countries for COVID, they isolated entire groups and they provided them resources. And by the way, the same thing happened with Ebola in places that were effective. Communities were supplied resources that people could isolate. So you ought to consider the entire household. The same thing happened with vaccinations. Do you really want to vaccinate one person in a household because they happen to be an essential worker and not vaccinate the entire household? What sense does that make? And how about testing? Do you really want to test particular people in a household and not provide testing for everyone at the same time? So right from the get-go, the idea of dealing with households, especially people living on the margin, especially people working in high risk environments, you have to think about everyone. So in our 501(c), our whole support system was there, not just for healthcare workers. It was for healthcare workers and their families. How can we support all of you so you can stay in the job? Because right now we have an over 20% attrition rate of healthcare workers. We don't have a COVID crisis here. That's not it. That's one of many crises we have. The big crisis we're facing right now is a collapse of our healthcare system. And I don't know what the situation is in Montana, but I can tell you in Arizona, it is our biggest issue here. It's not a question of how many beds we have anymore. It's how many staff do we have to man these beds. And we saw this happening in March 2020. This was all predicted. It was very obvious to see. And yet the resources were always focused on individuals. So if I had one thing as a health social scientist, as well as a public health person, if I could change one thing from day one, that'd be it. I have lots of other things I could share, but I'd prefer to stick with one that I feel passionately about.
Great, thank you, Mark. Very insightful. All right, I can see we've getting close to the hour. So unless somebody wants to sneak in one last shot on goal here, I think we will go ahead and conclude this seminar. Any takers? No? All right. Well, Mark, thanks again. So good to see you. Wait, I see a little hand from Marcy. Hi, Marcy, how are you doing?
Good. I was just saying thank you. That was a thank you so much.
Oh, that's a thank you hand. Hey, everybody do jazz hands for Mark. Thank you, Mark. And it was nice to see you again, Mark, and hope to talk to you again soon.
Yeah, all the best, and stay safe out there in Montana.
Will do.
We are not endemic yet. I know everybody wants to believe we're endemic. I'm as fatigued as everyone else, but guys, we're not there yet. Stay safe.
You too, Mark. Thank you.
Thank
Sure.
you.